You know, when you watch a movie, birth is, it's almost always portrayed the exact same way,
Oh, yeah. The classic grocery store scene.
right? A woman is standing in a grocery store, her water breaks, there's a frantic cab ride, lots of screaming, and then boom, suddenly there's a perfectly clean baby wrapped in a blanket.
Yeah, and it's treated like this, this sudden, almost magical event.
Exactly. But if you actually look at the clinical reality, I mean, it is nothing like that. It's this astonishing, highly coordinated biomechanical and physiological puzzle.
It really is.
So today, we are stripping away the intimidating medical jargon from a really comprehensive clinical text on the 5 Ps and processes of labor and birth. We're doing a deep dive into the invisible gauntlet that you, me, and literally every single one of us survived to get here.
It's the ultimate biological puzzle.
Okay, so let's unpack this because
Yeah.
birth is essentially a high-stakes puzzle of physics, anatomy, and just extreme endurance.
Yeah, and the clinical framework we're looking at today organizes this whole incredible event into what they call the 5 Ps,
Right, the 5 Ps.
which are passengers, passageway, powers, position, and psychologic response. But to truly appreciate the pure physical mechanics of how we all made it into the world, we're going to focus entirely on the first 4 Ps today.
So strictly the physical stage and the engine that sets it all into motion.
Exactly. Setting the physical stage before we set it in motion.
Let's start by looking at the traveler and the terrain then. What the text calls the passenger and the passageway.
Right.
I like to think of this like, imagine trying to move a very specific, oddly shaped piece of furniture down a narrow, winding staircase.
That's a great way to picture it.
But the twist is the furniture in the scenario literally changes its shape to fit the staircase.
Yeah, and the passenger is, of course, the fetus. And the most critical part of this passenger is the head,
Just guesses the size, right?
because of the size and its relative rigidity. But the thing is, the fetal skull isn't a single solid sphere of bone like an adult's.
Which is lucky for the mother, honestly.
Very lucky. It's actually composed of separate bones. You've got 2 parietals, 2 temporal, the frontal, and the occipital bone.
Okay.
And they are all united by these flexible connective tissue seams. They're called sutures.
Sutures. And where those seams meet, that's where you get the fontanelles, right? The soft spots.
Exactly, the soft spots. And the text actually mentions there are 2 primary ones that matter here.
Yeah, I saw that. The larger anterior fontanelle, which is diamond-shaped, and that one takes, what, about 18 months to fully close after birth?
Roughly 18 months, yeah. And then the posterior one is triangular, and that closes much faster, in just about 6 to 8 weeks.
Wow. But during labor, I mean, those flexible sutures and fontanelles are doing a lot of mechanical work.
Oh, it's vital. They allow the skull bones to literally slide over one another and overlap.
Overlap, like they actually stack up on each other.
Yes. It's a process called molding. The baby's head actively changes shape to adapt to the diameters of the maternal pelvis.
That is wild.
It can look quite extreme right after birth, too. Sometimes the head looks, significantly elongated.
Right, the classic cone head baby.
Exactly. But most newborns' heads return to their normal rounded shape within about 3 days.
Which is just crazy to think about. The traveler is literally packing itself down to fit the path.
It really is.
And by the way, the text notes that in about 97 to 98% of births, the baby enters this path in a cephalic presentation, meaning head first.
And to first, yeah.
But what about the path itself, the passageway? Because the mother's rigid bony pelvis is the primary obstacle course here. And human pills are not all identically shaped.
No, they aren't at all.
Yeah.
The text categorizes them into 4 basic types. And the shape you have fundamentally dictates how the baby has to navigate the descent.
Okay, so break those down for me.
So first you have the gynecoid pelvis. This is the classic rounded female shape. It's found in about 50% of women.
So half the time it's this gynecoid shape.
Right, and because it's a wide, even circle, it provides the most straightforward path.
Okay, makes sense.
Then there's the android pelvis. This one is more heart-shaped, and it actually resembles a typical male pelvis. That's seen in about 23% of women.
And I imagine if the pelvis is heart-shaped, the baby's head can't just drop straight down however it wants.
Exactly.
The geometry is going to force the baby to align differently to find the widest available space.
You hit the nail on the head. The terrain dictates the rotational path.
Wow.
And you see this even more clearly with the anthropoid pelvis. That one is oval-shaped and makes up about 24% of cases.
Oval-shaped, meaning longer front to back.
Yes. Because the oval is longer front to back, the baby often enters the pelvis facing straight forward or backward rather than sideways.
Got it. And there was a fourth one, right?
The Platyploid pelvis. It's flat and wide,
Yeah.
but it's pretty rare, found in only about 3% of women.
Oh, okay.
With a flat pelvis, the baby has to enter completely sideways just to fit through the narrowest point.
Okay, so here is a pushback that came to mind while I was reading through all these precise geometric requirements.
Sure, what is it?
If it all comes down to geometry, like the specific size of the passenger's head matching the very specific shape of the passageway, and we live in an era of super precise modern imaging like CT scans and MRIs,
Mm-hmm.
why aren't doctors pre-measuring every mother's pelvis to guarantee a perfect fit before labor even begins?
What's fascinating here is that the clinical text explicitly addresses this exact question.
Oh, really?
Yeah. It notes that pelvimetry, measuring of the pelvis via MRI or CT, is rarely beneficial. And actually, relying on it can lead to unnecessary surgical interventions.
Wait, why? If you have the exact measurements, shouldn't that be safer?
Because the body is fiercely dynamic. You can't just look at a static image and predict a birth.
Because things move.
Right. During late pregnancy, hormonal influences cause the maternal pelvic joints and ligaments to relax. They become highly mobile.
So the bones actually shift apart.
Yes. The soft tissues in the birth canal stretch and accommodate to an astonishing degree.
Yeah.
And like we just discussed, the baby's head molds and changes shape.
Right, the molding. So a static snapshot of bone structure just can't predict that real-time biological adaptability.
Exactly. It's a moving target.
Okay, so if the baby's skull is shifting and the mother's pelvis is relaxing, you have this perfectly primed mechanism.
Right.
But a mechanism doesn't move itself. The terrain and traveler are set, but something has to provide the force to push that traveler down the terrain.
And that brings us to the powers.
The powers, yes.
The powers are the forces that actually expel the fetus and the placenta. And they're divided into two distinct categories, primary and secondary.
Okay, so the text describes the primary powers as totally involuntary. I pictured them kind of like a massive tidal wave, completely autonomous.
That's a good analogy.
And then the secondary powers are voluntary, like a surfer actively paddling a surfboard to catch and ride that wave.
I love that. So the primary powers are the uterine contractions.
Okay.
They originate at specific pacemaker points in the thickened upper muscle layers of the uterus, and they sweep downward in these rolling waves.
Pacemakers, like the heart.
Exactly. And these involuntary waves have two massive jobs during the first stage of labor: effacement and dilation.
Let's make sure we paint a clear visual of those two jobs for everyone listening.
Sure.
Because normally the cervix is like a thick, muscular bottleneck at the bottom of the uterus, right? About 2 to 3 centimeters long.
Right.
So effacement is the thinning of that bottleneck. The contractions essentially pull that muscle upward, just obliterating it until it's paper thin.
Yeah, and in clinical terms, that's measured in percentages, from 0 to 100% effaced.
And then dilation is the opening of that thinned out cervix.
Yes, widening from less than a centimeter all the way to 10 centimeters.
Which is the diameter required for the baby's head to pass through.
Exactly.
Okay, so the primary powers are doing all that heavy lifting to open the door.
Yeah.
But I do want to ask for some clarification here on just how independent these primary contractions are.
What do you mean?
Well, you call them involuntary, but how autonomous are they really? Like, is the brain still controlling them?
They are staggeringly autonomous. Actually, the text highlights a fact that truly illustrates this.
Okay.
Laboring women who are completely paralyzed from spinal cord lesions above the 12th thoracic vertebra, they still experience normal, effective uterine contractions.
Wait, seriously?
Yes, they simply do not feel the pain of them. Even heavy epidural analgesia doesn't stop the frequency or intensity of these primary powers.
Wait, let me just sit with that for a second.
It's wild, right?
Even if the brain's conscious connection to the lower half of the body is entirely severed, the uterus just keeps going.
Just keeps going.
It essentially has its own localized survival programming. That fundamentally changes how I view human organs.
It really does.
It's operating like a completely standalone engine to ensure the baby is delivered, regardless of what the central nervous system is experiencing.
It acts on an involuntary autopilot to secure the survival of the species. The body simply takes over.
Okay, so if the primary powers are on full autopilot, when do you paddle the surfboard? When do those secondary powers kick in?
Right, the secondary powers. That happens when the presenting part of the baby finally reaches the pelvic floor.
Okay.
The mechanical stretching of the posterior vagina triggers these stretch receptors, and this causes a sudden release of endogenous oxytocin.
Oxytocin, the hormone.
Yes,
Yeah.
which creates an overwhelming involuntary maternal urge to bear down.
Oh, so even the urge is sort of involuntary.
It is. It's a physiological response called the Ferguson
The
reflex.
Ferguson
Yeah.
reflex.
And that is when the mother uses her secondary powers, contracting her diaphragm and abdominal muscles to actively push and increase the intra-abdominal pressure.
Okay, and this dual engine process, the primary and secondary powers, it plays out across the 4 stages of labor.
That's right.
The first stage is all about those primary powers, right? Getting from the onset of regular contractions all the way to that full 10-centimeter dilation.
Yes, and the text notes this is by far the longest stage.
Then the second stage goes from full dilation to the actual birth of the baby.
Correct. And it involves a latent phase where the baby passively descends under the force of the primary contractions, and then an active phase where the mother uses those secondary powers to push.
And stage 3.
The third stage is the delivery of the placenta.
Right. And finally, the fourth stage is that crucial 1-hour physical recovery period right after birth where the body begins to stabilize. Okay. So we've established the intricate path and we understand the dual engine of the powers. Now we have to combine them.
Yes, putting it all together.
Because the presenting part of the baby is actually quite large in proportion to the maternal pelvis, a very precise required sequence of movements has to happen for the baby to actually navigate the exit.
And the text calls this the mechanism of labor.
Right.
It involves 7 cardinal movements. And while we list them out sequentially to understand the physics of it, it's really important for you listening to remember that these are often happening simultaneously.
Yeah, it really reads like a highly choreographed dance or like navigating a specialized lock-and-key mechanism.
Very much so.
Let's work through the steps. Step 1 is engagement.
Yes.
This is when the widest transverse part of the baby's head, the biparietal diameter, passes into the pelvic inlet. It's basically the moment the baby is officially locked into the path.
Exactly. Which leads directly to step 2, which is descent.
The progress of the head moving down through the pelvis.
Right. And in clinical terms, this descent is tracked by something called station.
Station. Now, the text mentions stations from -1 to +4 +5. But to picture this, we need to know where station 0 is. What is the baseline here?
Okay, so the baseline is mapped against the mother's ischial spines.
Ischial spines.
Yeah. If you picture the pelvis, these are 2 bony protrusions about midway down the internal cavity.
Okay, I'm picturing it.
When the lowest part of the baby's head is perfectly level with those bony spines, it's at station 0.
Got it.
If it's a centimeter above those spines, it's -1. As it descends below the spines, it moves to +1, +2, and so on. Birth is imminent around +4 or +5.
Okay, so the baby is descending, but the canal isn't a straight, smooth drop.
No, definitely not.
If the baby's head just stays looking straight forward as it hits the curves of the pelvis, it's going to get stuck, right?
Exactly. Which forces movement 3? Flexion.
Flexion.
Yes. As the descending head meets physical resistance from the cervix, the pelvic wall, or the pelvic floor, the baby's chin is literally forced down onto its chest.
Oh, tucked in.
Right. This is crucial because it presents the smallest possible diameter of the head, which is about 9.5 centimeters to the birth canal.
That is so efficient.
Yeah.
And then the baby has to twist. Step 4 is internal rotation.
Mm-hmm.
The text points out that the pelvic inlet, the top of the path, is widest from side to side.
Right.
But the pelvic outlet, the bottom of the path, is widest from front to back. So mid-descent, the baby's head has to rotate 90 degrees just to fit.
Yes, a full 90 degrees.
But does the baby actively know to perform this complex routine? Or is it purely a matter of physics?
It is spectacular biomechanics. The baby isn't actively deciding to turn. As the head descends, it meets a hammock of maternal pelvic floor muscles called the levator ani.
Levator ani.
Right. You can picture this muscle layer like a biological trampoline that slopes downward and forward.
A sloped trampoline.
Yes. So the mother's anatomy acts as a rigid, guiding dance partner. The physical resistance of that sloped muscular hammock, combined with the shifting shape of the bony pelvis, literally catches the baby's head and physically routes it into the correct rotational alignment.
Wow. So it is pure physical guidance.
Completely.
The shape literally dictates the turn. That makes perfect sense.
It's incredible design.
So after it rotates, we reach step 5, extension.
Yes.
The baby's head reaches the perineum, passes under the pubic bone, and deflects upward. The head is born. The back of the head first, then the face, then the chin.
Which leads right into step 6, restitution and external rotation.
Okay, wait, what is restitution?
Well, remember, the head just twisted 90 degrees to get out, but the shoulders are still inside.
Oh, right, they haven't turned yet.
Exactly. So once the head is free, It immediately untwists 45 degrees back to the position it was in before it engaged.
To realign with the shoulders.
Yes. This realigns the baby's head with its own shoulders, which are now navigating that exact same internal rotation inside the pelvis.
That is just brilliant. And finally, step 7 is expulsion.
Yes.
The shoulders slip under the pubic bone, the baby is lifted, and the rest of the body flexes out. The second stage ends.
We made it.
We did, though I do want to quickly mention something called asynclitism, which the text brought up.
Oh, yeah. That's an important detail.
Sometimes the baby's head isn't perfectly straight on its axis. It tilts slightly toward one shoulder or the other to facilitate descent.
Right.
It's almost like you'd angle a large sofa sideways to get it through a tight doorway.
Right.
It just further highlights how dynamic this geometry has to be.
The lock and key analogy holds up, but it's a lock and a key that are both constantly shifting, yielding, and negotiating space with each other.
Okay, here's where it gets really interesting. Because moving a baby through this mechanical gauntlet isn't just an anatomical feat.
No, not at all.
It requires extreme physiological adaptations and stress endurance from both the mother and the fetus.
Extreme is the right word.
The mother is essentially running an ultramarathon while the baby is doing a high-pressure deep-sea dive. Let's talk about the toll this takes.
The physical demand on the mother's body is profound. Let's just look at the cardiovascular changes.
Okay.
During the first stage of labor, maternal cardiac output surges by 12 to 31%.
Wow.
And that is primarily because with every single contraction, an average of 300 to 500 milliliters of blood is violently shunted out of the uterus and back into the maternal vascular system.
Wait, 300 to 500 milliliters? With every contraction, that is a massive volume of blood shifting around her body every few minutes.
It's an immense physiological load. The blood pressure spikes during contractions.
I bet.
The white blood cell count increases dramatically too. It mimics what you'd see during major tissue trauma or extreme athletic exertion.
Oh, so the body is instantly preparing its immune defenses for healing.
Exactly. The respiratory rate shoots up, sometimes causing hyperventilation. Even her gastrointestinal motility just plummets.
Meaning her digestion starts.
Pretty much. The body diverts so much energy and blood flow away from digestion that stomach emptying slows to a crawl, which is why nausea and vomiting are so common during labor.
It is a full system override. Digestion is an unnecessary luxury when the body needs all its energy to power the uterine engine.
Exactly.
But what about the baby? Because they are in the middle of this intense squeeze.
Right.
The text notes that a normal fetal heart rate is a rapid 110 to 160 beats per minute. But during those intense contractions, blood circulation through the maternal arterioles to the placenta temporarily decreases.
Yes, it drops.
I have to push back here. Cutting off or dropping blood circulation and oxygen supply during contractions, that sounds incredibly dangerous. How is that biologically safe for the baby?
This raises an important question, and it's actually one of the true marvels of fetal physiology.
Yeah.
It is a stress test. But a healthy fetus with adequate placental circulation has built-in reserves to compensate for this temporary drop in oxygen.
So they can hold their breath, essentially.
In a way, yeah, they are evolutionarily designed to withstand it.
Yeah.
But even more fascinating, this physical squeezing and this temporary chemical stress are actually highly productive.
Productive.
They are essential for survival outside the womb.
How so? The stress is actually serving a function.
Absolutely. Think about the baby's lungs. Throughout the entire pregnancy, the fetal lungs are filled with fluid. They aren't breathing air.
Right.
The immense physical pressure of being squeezed through the birth canal acts like a ringer. As the baby's chest passes through the narrow passageway, the mechanical compression forces that fluid out of the fetal lung passages.
So they are clear and ready to take in air.
Yes.
The physical pressure literally clears the airways.
It does. Furthermore, that temporary decrease in circulation we talked about that causes a drop in the baby's oxygen levels and arterial pH, while carbon dioxide naturally rises in the blood. These exact chemical shifts stimulate the chemoreceptors in the baby's aorta and carotid bodies.
Wait, let me make sure I'm connecting the dots here.
Go ahead.
The chemical shift from being temporarily deprived of oxygen during the stress of contractions, that is the exact trigger that tells the baby's brain to take its first breath.
Exactly. The physiological stress of navigating the birth canal arms the respiratory system.
That is unbelievable.
So the absolute second they hit the open air, their brain is chemically screaming at them to breathe. Without the physical squeeze and stress of labor, that respiratory transition to the outside world is often much more difficult for the newborn.
Wow. So, what does this all mean? As we bring this deep dive to a close, I really want you, the listener, to think about what we just covered.
It's a lot to take in.
It is. The journey from the womb to the world isn't just a simple medical event, it is an intricately engineered puzzle of survival. It is overlapping skull bones, shifting pelvic joints, tidal waves of involuntary muscle contractions, and a highly choreographed seven-step dance through a twisting, narrow corridor. You and every single person you have ever met survived this invisible gauntlet of mechanical turns and intense biological stress.
And if we connect this to the bigger picture, there is one final detail from the source material that acts as the ultimate aha moment.
Oh, lay it on me.
We've talked extensively about how the mechanics and forces execute the process of birth. But what actually flips the on switch to start labor in the first place?
Yeah, what starts the engine?
For a long time, the onset of labor was purely attributed to maternal hormones, like a drop in progesterone and a rise in oxytocin.
Right, the mother's body initiates it.
That's what we thought. But the text notes that hormones produced by the normal fetal hypothalamus, pituitary gland, and adrenal cortex likely contribute heavily to the onset of labor.
Wait, let me just pause on that. You're saying the baby isn't just a passive traveler waiting to be evicted. The baby's brain literally helps send the chemical signal to start the very engine of its own birth.
Precisely. The fetus reaches a level of maturity, the fetal brain releases the necessary hormones, and those signals cross over to influence the maternal system.
Wow.
It is the ultimate biological collaboration between two bodies.
That is profound. I want you to just sit with that thought today. We often think of ourselves as having simply been born, as if it just happened to us.
Right.
But in reality, you actively helped initiate the process, and then your body dynamically navigated an impossible labyrinth.
You earned your way here.
You really did. So the next time you see a movie where someone's water breaks in a grocery store and they instantly have a baby, remember the twisting staircase.
Remember the folding skull.
Remember the engine that runs on autopilot. Keep questioning the amazing processes hiding right under our noses. Thanks for taking this deep dive with us.